a good personal friend, a really respected scientist and researcher and clinician in that space between dementia and primary care. And we're so pleased that he could be here with us today. And Malaz, I think you're all set, so please come on.
Good morning, good afternoon for you all. I've been very, very impressed so far with the location and also with you all and your engagement. So what I'm going to try to share with you today, it's a little bit of different than what you heard from this morning. It's more of a system look. All right, how can you fix the problem from a public health perspective, a population health perspective? And then after my talk, if anybody want to zoom in a little bit more, we can take a walk on the river bond or somewhere else. So you can do whatever you want. All right, so just an FYI. All right, so let me start first with potential disclosure. These are my conflicts of interest. I founded a couple of companies. Some of them specifically DigiCare realized might be relevant for the content of what I'm talking to you. So keep that in mind. These are the sources of funding for the past 20 years that contribute to the content and the knowledge that I'm sharing with you. So if you are a taxpayer, thank you so much. I'll let you know. I try not to waste your money. And what I'm trying to figure out is two things. I'm using all these data that we have gathered in Indianapolis and been replicated outside too. I'll try to identify from a system perspective the barrier and facilitator for optimal identification of patients with dementia. And then I'll give potential solution based on that evidence, okay? But these solutions are system solutions. They're not gonna tell you exactly what you have to do in your clinic or in that encounter that you have with your patients. So this is how we see the world of primary care. I don't think have changed that much, but it's important for you to see it when we try to figure out a solution. We always try to see it with this lens, because otherwise our solution become non-sustainable, non-scalable, and not relevant. And this is one of the biggest problem when you do research in a different environments, like in a heavy memory care clinic where 50 to 90% of the patients have cognitive impairments. Lessons learned from there are very, very hard to transfer to another setting where the prevalence of dementia is around 10% or so, all right, or less. So it's important for you to know how we see the primary care. This is a snapshot of primary care focus on older adults, all right? So assuming a panel of 2,000 people or so that a primary care clinician taking care of, usually 300 of them are older adults, and these older adults have a lot of comorbid condition. On average, take 12 prescribed medication, and they pay, this is almost 10 years old, they pay $400 out of pocket per month of managing all these other things. The primary care clinician, all of you here, they have to navigate and they have to orchestrate a very competing recommendation, all right? And without their conductions ability, it doesn't make any sense, all right? So they are, for me, the primary care clinician are really the conductor of the symphony of population health. All right? But this symphony, without them, you got a neurologist who think, take donepezil, an example. Life is all about your memory. And then you have a urologist over here and think it's all about the bladder. And a lot of times the bladder and brain are not aligned. All right? So this is very, and the same thing for brain, for the conflict between brain health and cognitive and kidney health or other organ specific. And on top of it, if the primary care clinician listen to the recommendation of the experts, and the United States Preventive Service Task Force and shut down their business for acute care. So you don't do any urgent care, you outsource urgent care to somebody else, you're just there for chronic care management and preventive health, then literally a typical primary care clinician, just to follow these recommendations, has to work a lot, 17 hours a day. That leaves 7 hours for everything else, including going to the bathroom. So you have to be very efficient. And then on top of everything, I don't know if this is relevant to Georgia, but at least in the Midwest and East Coast and West Coast, this whole transformation from volume-based to value care, people thought it will be helpful, but it's bring a lot of challenges, a lot of different regulation and different documentation. So it didn't really help that much. It's just made you now living in two worlds, like one here and one there. All right? Except if you're lucky with a big risk like CareMore or other system. So why, given all that perspective, why should we even think as a primary care clinician to taking care of early detection of Alzheimer's disease? I'm going to share with you 5 bullet points that, in my opinion, primary care clinician, this is why we are primary care clinician. I'm an internist and a geriatrician. It's number one, we know sending our patient to the hospital if they don't need it is not walk in the park. All right? Especially now when we have no primary care clinician who come over to the hospital that many times. You have to do the handoff of the hospitalist. So that's number one. If you have cognitive impairment and you're not recognizing, that number of inappropriate ED visit hospital double to triple. So that's number one. Number two, if your primary care clinician and you're taking care of the below the neck care, so heart failure management, diabetes management, hyperlipidemia, all the stuff that we saw during the discussion with Dr. Cohen. Should I give statin or should I not give statin? What is e-prognosis? All these kind of things. All your recommendation will go nowhere if your patient have dementia because they're not going to take any of your drugs. You might see it on Epic, 12 medication. You go to their home, they have nothing. All right. So if they have cognitive impairment and you're not recognized, your argument with Dr. Cohen it become irrelevant. All right. Just FYI. So that's the big one. Then the other type of it, these patients who have unrecognized dementia and you are in the front line, they are at risk for injury. Not just physical injury like driving accidents and fall, but even exploitation. My father-in-law, and Ted know this, we as a family lost $300,000 because he became a victim of financial exploitation and he lived in rural Kentucky surrounded by an amazing family and he was an insurance manager and he was really awesome. We lost $300,000. All right? Ironically, the community broke a law and the U.S. Postal Office contacted his family to say, I don't know, but this is the third visit that your father and your mother are coming over and pulling, not a check, even money order, and taking it with us. And this is like the third time for $20,000. I don't know. So they're not supposed to share that. But with the small community, you care. And somebody read the flag, and we went through it. All right? And then this undiagnosed dementia, it's happening even though the numbers of cognitive complaint, people are knocking on your door with cognitive complaint. And unfortunately, our clinical system saying, it's not that important. It's just age. Okay? And then if you care about equity or DEI, which we all saw what happened in the past 3, this problem I'm saying with you, it's very prominent in very vulnerable populations, including those who have very low social determinant of health, in a certain neighborhoods, underserved populations, wherever they're coming from, not just African American and Hispanic, even some of my group who are right now, it's from the Middle East, a lot of Syrians, a lot of North African are coming over and immigrate, and they carry with them these things, and they have even more a problem. These are all negative. These are all negative. But it's 2023, and there's been amazing 3 breakthrough that now we can make sure access to these 3 breakthrough. So the big one you didn't know about is brain prevention bundle. I think, Chad, you mentioned it maybe early on, or maybe Gabrielle. I don't remember. One of you mentioned, it was you, correct? Yeah, the Lancet paper of 2020, it showed actually that if you are at risk for developing Alzheimer's disease and other related dementia, and you follow lifestyle modification, your risk can be reduced by 30%. 30%, just FYI. Now, it's lifestyle modification, which is really hard, changing human behavior, correct? It's not a pill. You put it over there, you swallow it. It's very hard, I know. Cool? It's very, very hard, okay? But it's still 33% reduction in your risk. And if you get unlucky, and you did everything you could, and you were one of these 70 people who developed Alzheimer's disease, but now we heard if you get a little bit lucky after that, so unlucky to develop Alzheimer's disease, lucky that you have a person, a doctor who can come over and identify you in the early stages, like mild cognitive impairment, and you get lucky and you have a biomarker for Alzheimer's disease, within 18 months, I reduce your trajectory by 30%. All right, okay, that's good. What if you were really, really unlucky? So you were unlucky to develop Alzheimer's disease. You were unlucky that you were early identification, but you were not eligible for these medication, or you couldn't tolerate them. Now the 3rd breakthrough is the GUIDE model, or the collaborative dementia care model, will help you tremendously if you want to stay at home, not go to the nursing home, and I don't know if any of you want to go to nursing home, but just in case. If you want to stay at home, you want to optimize the quality of life, you and your loved one, there's now caregiver-based a GUIDE collaborative care model that was approved in July 31st, 2023, that will make the care providers who do that rich, all right? Like, we will get finally paid for collaborative care model that we developed for almost 20 years, and Emory has the same thing, all right? So these are 3 breakthroughs. So there's a lot of things you can do now to keep your brain healthy, or reduce the trajectory, or even keep your quality of life. All right? So why we are not doing that, I'll tell you my story and the data, but let me give you like the in a nutshell, because we practice medicine what I call below the neck. All right? We have a system right now that's very good below the neck. Above the neck, if you have mental health, see you later. Cool? And cognitive health, see you later. And we saw that a lot, okay? But that's the problem with the system. Despite the high intelligence level of our clinician and high empathy, all right? You saw it. Our clinician in the front line risk their life. They didn't just talk like me. I'm a researcher. I wasn't in the front line. I can always preach, but you guys were in the front line. Some of our clinicians died in the front line in the past 3 years. All right? Despite we have this amazing, high empathy, trustworthy workforce, our system's still below the neck. All right, so what can we do? So a big myth, and it's important for you to know that I made the case dementia burden is very high, dementia recognition is very low. Automatically, you think, let's just screen everybody. All right? And the United States Preventive Service Task Force last time looked at this question, which is anybody 65 and older, just come over to your clinic, you screen them to see if they have dementia or not. The benefit and harm was not clear, and they gave it a recommendation of I. All right? Now, if you are a neurologist and geriatrician who specialize in cognitive impairment like myself and geriatric psychiatry, you will think the U.S. Preventive Service Task Force are just cool, heartless people. All right? But they have a very different question. They look at harms and benefits for people who are coming over to your clinic and not knocking on your door and say, I have symptoms. All right? And for them, the burden of benefit harm is very different than the group who come over for your diabetes. And you say, oh, by the way, let me just do colonoscopy for you. All right? You have to make sure the colonoscopy benefit outweigh the harms. And the U.S. Preventive Service Task Force does this. All right? So what did they found in the United States Preventive Service Task Force? They found a lot of gaps. And since 2003, we've been going after that gap. So the first gap, what will happen if you implement dementia screening and diagnoses in primary care? We did that in the early 2000s. We repeated in 2010, and now we're doing another wave around 2020 or so. And here's the reality, all right? In the real world, in the reality, number one, the screen positive rate, despite what you hear for dementia, if you set up the criteria on dementia, went down from 13% to 8%. And that's actually in parallel, and the incidence rate of dementia actually went down for the past decade. Now, the numbers went up because of the aging, all right? So we saw the same thing in primary care in the screen positive. The big one among those who screen positive, a lot of them, they didn't come over and ask for your help, but we proactively did it. A lot of them refused another diagnostic assessment. 67% refused diagnostic assessment. It used to be 48%, now it went up to 67%. Despite us saying we will send a team to your home to do it and everything else. So you can't run dementia screening and diagnoses if you have these numbers, all right? You can't do that. Imagine you're doing breast cancer screening and 67% of those who screen positive on mammogram refused undergoing biopsy and other diagnostic workup. There will be no benefit of the mammogram anymore. All right? The benefit screening require taking action on the next, and the action you take, the benefit outweigh the harms. Okay? So who are these folks who screen positive for dementia? So that's one thing. If you do general asymptomatic people, maybe the benefit harms, at least by the United States Preventive Service Task Force, is insufficient. What about if you become what we call targeted population or segment the population more? These are the folks who screen positive for dementia. They are older, obviously, we know that. Lower education is still prominent. Low education. But the good news about lower education, the first study we did in primary care in 2000, the average, 65 and older, the average education in a population where we are 50% are dual eligible, like Medicare and Medicaid, around 50% are African Americans. The mean average education level in 2001, 7. I looked at the data yesterday, and now it's around 13.5. All right, so the generation is changing a little bit, all right? So that's a good news, but if you have low education level, you're likely to screen positive, and maybe it's a false positive, so just an FYI. The second one, if you self-reported forgetfulness, you have higher likelihood to have cognitive screen positive. If you are in an urban setting, it's more likely than rural setting, and if you do it face-to-face, it's more likely to screen positive than by telephone. What that means is there's a lot of things going on there on your platform you use, you know? It's like, you can't imagine why urban and setting everything. So it may be surrogate for something else. It's surrogate for the selection, the people who come on over and do this stuff. So you have to take that into account. So that's one information. The other information you heard from today, what about a blood test? All right? What about blood tests? And we have at least a couple available on the market, and they are not FDA approval and require somewhere around $400 to $1,200, $1,500. What about these? These tests, you have to make sure that, number one, for a population perspective, they cost low, ideally less than $10. None of them cost less than $10. Right? Number two, they have a good accuracy, area under the curve of 80% or so. They're supposed to have no harms. You all in the primary care, and you've been living the PSA controversy, correct? You don't want to have another PSA controversy, okay? And then obviously the big question of screening is the benefit or harm of screen-detected cases are supposed to be better if you leave the current state, keep going. All right, so that's the big question. And finally, you can do all this stuff. If nobody wants CSF or PET scan or being screened, even with a blood test, then your system is not going to work. So when we start digging deeper into who are these people who are refusing screening or at least refusing diagnostic assessment, we start finding out some early and strong signs of stigma. Okay? And these stigma, if you think about them a lot, we call them the 3D of stigma. Number one, they feel if you find out I have Alzheimer's disease, you're going to take my driver license. And have you been on a public transportation? Ain't working very well. So what the heck is this? All right, number one. Number two, you're going to take away my dependence. I'm not going to trust you. You're going to take me because you and my family member might put me in a nursing home. I ain't going to the nursing home. So that's the second one. The third one, you're going to take away my dignity. You think I'm crazy. You're not going to respect me. You're not going to take care of me. And you already is not doing so. Now you're going to add to it cognitive impairment. So dignity, dependence, and driving, and that's the major source of the stigma that we found. And it's ironically higher in the people who used to be caregiver. So these are caregiver for people who had Alzheimer's disease. Now we ask them about themselves, And again, in primary care, this is not self-selection. Remember, the people who come over to my clinic as a memory clinic are very different. They already passed all the barrier. Their daughter said, come on, we're going. The first time she came over and he wasn't ready. Then the second, they canceled with Dr. Boustani. So can we reschedule, please? So on the third time they came over, they are very different people. They already engaged. And primary care is very different. And just this concept of contacts is a major source of controversy between specialists and primary care. All right? Big difference. And ironic, the specialists like myself look like judgmental, correct? Like, you primary care. So do you want to switch? Let's switch, man. Come on, let's switch. No one is switching, so just FYI. The other thing we tried to find out, who are the people who are screen positive, but they didn't come back for diagnostic assessment. Who were they? So obviously there was a significant interaction between race and age. All right? So if you're an African American and older, you will be more likely to refuse. If you are white and younger, you are most likely to refuse. What? So there's something over there. And then the big thing also we notice is depending on how you answer your temporal orientation question. All right? If I give you the total score and it was it was positive, but you answered the temporal question, like what's today's date? What day of the week is it? And you correctly answer that, doesn't matter if you flunked the rest of the score. They think, I'm doing well. I don't know what's going on with you. Nothing going on. All right? So these are detailed stuff. Until you do this kind of research, you go with what I call superficial judgment. All these neurologists, geriatricians who special memory care, they make that judgment, but they're not in that context. And we know what happened when you don't know context. A lot of unintended consequences. You think you're doing benefit, you might lead to harms. All right? And I'm one of the people who cause harm, so I just want to let you know. I thought screening for cognitive impairment in the hospital would be awesome. We did a clinical trial. It didn't work. The only thing else, people discharge on Haldol. So just FYI. Unfortunately, cool? This is the unintended consequences when the system is not ready for what you think would be good for an ideal situation. So So based on that, we did a dementia screening trial. This was the first dementia screening trial, similar to screening for mammogram for breast cancer. We did this, and this information would contribute to the United States Preventive Service Task Force. And so we enrolled, look at this number, almost 4,000 people, 65 and older, attending primary care in urban, rural, and suburban, but in Indiana, central Indiana. We randomized them to screen versus screen plus. And we followed them just for 12 months. And what we found, health-related quality of life, no difference. That was our main outcome. But no depression. All right, so people did not freaked out when we screened positive. So that was good news. We found no benefit, but no harms. Anxiety and depression was really good. Okay, so with that background and all the work that we've been doing for 20 years, so how can you optimize the early detection of Alzheimer's disease and other related dementia in primary care, given these two breakthroughs, the GUIDE model, the collaborative dementia care model, and the disease-modifying agent. So here's my solution. I haven't proved it yet, all right? Wait for 3 years, we'll find out. But for now, it's just solution based on my intuition. No evidence to back it up. Number big one, there's a stigma, guys. There is a stigma, not just among our patients and family members, among our healthcare providers. In 2021, we published data with the AARP about healthcare providers, and healthcare providers on average have 20% worse perception about dementia than their patients. All right? They are more scared from dementia than the patient, and maybe for good reason. So I don't know, but there was a gap, okay? There's a stigma, significant level of stigma. And because of that stigma, there's not much demand, all right? So if you think about logically, I'll start with myself. I'm supposed to be a logic person. I really want to live as long as possible, but with a good brain. Cool? Like that's really my goal. If you think that will be the case, I will be knocking on I will have a primary care doctor. I don't have a primary care doctor, sorry. So I don't have a primary care doctor, but I'm supposed to be a primary care doctor because primary care doctors are the best that we have for prevention. They are the one who reduced coronary artery disease over the past 20, 30 years, all right? They are the one who took care of the diabetes and everything else. They're set up as a really first line of public health perspective. I don't go there. I don't knock on the door of primary care doctor and say, hey, tell me what can I do to keep my brain healthy, even though I know there's no brain transplant. Really, there's kidney transplant, lung transplant, heart transplant, face transplant, but there is no brain transplant. So technically, you lose your brain, you're screwed. Sorry. Now, we can figure out some neuroscience, ChatGPT and stuff to help with you, but that might not become who you are, all right? So there's fundamental stigma that's driving no demand, all right? And until we create demand, and I think one of it is overcome the stigma, that's not going to be a problem. The second one, you heard it this morning, the perception of our providers, there's nothing you can do. And I already showed you the collaborative dementia care model. We know this since 2006. In 2006, we said if you care about not going to the nursing home, not going to the hospital, optimize the quality of life and your loved one, and reduce your behavioral and psychological symptom, we had a care model that costs around $1,000 per member per year and save for your health insurance $3,500, netting $2,500. How many people we have provided this care model for? In Indiana, 5,000 people max, since 2006. In UCLA, where they have done similar, it's around thousands, 2,000, let's say 5,000 too. In Hopkins, 5,000. I think in Emory too, how many people you have saved with the collaborative care model?
Right now it's a panel size of 500.
500. Over time, let's say 5,000, correct? 5,000 only. So altogether, maybe 50,000 people. And there's at least 5 million Americans, all right? Big difference. So we have to say there's a lot of things we can do for dementia. And finally, look, the workflow is the workflow. Today I talked in a functional assessment, and the average number of visits that primary care clinicians see was 20 to 22. 20 to 22. How can you do it? We think we have to be innovative using something we call passive digital marker to help with making workflow optimization. So how can we do this? This is now my solution. We map the journey of a patient through the system who care about their brain. They start going to the primary care patient. Still, majority of our population, primary care is the most trustworthy first contact with. All right? And then after that, maybe what we can do, instead of taking care of the brain of everybody, we think we can pick up people at high risk. So how can you be high risk? First of all, if you have cognitive concern. So if your patients came over and say, I have concern about cognitive problem, take them seriously. Or worse, or more important, if their family member did what we call hold on a second action. Do you know the hold on a second? So I'm coming over with my family. You are my primary care doctor. You're going to go see them. I say, hey, can you just talk to you? Can I talk to you? That's mean there's something going on. You listen to them. That's a red flag. You don't need to have ChatGPT to tell you this. If somebody, family member, showed up, number one, and hold you, it's good. And one of our neurologists said, during today said, if somebody who came over and did not get lost, and make it to my complicated clinic, and has everything else, pass the cognitive testing. So that's another way you can figure it out, all right? So after you do this, for these people at high risk, I think in the current healthcare system, you can do it with the resources you have. Even if you loved it, you won't be able to sustain it. My solution is bring resources. And for us, you don't need MA. We think community health worker can come over and help with the brief cognitive assessment, navigation, and everything else. That's where we think the solution is. And then you need to have a system in place to ready, like what you have over here with the memory clinic, to tell you what to do, and hand over. So this, if you look at this journey, it's not plain, it's like a relay sprint, In the relay sprint, the weakest point in the relay sprint is the handoff, all right? So you need to create a system that have a beautiful handoff. This is our passive digital marker. It requires 0 time and requires less than 1 cent per person. What we do here, we look at the data left behind by your patients in your medical record, and we take that data and tell who will develop Alzheimer's disease in next year or 3 years. We have an accuracy, not 80% accuracy, somewhere around 70%. So it's a good starting point. The other one is patient-reported outcome. You saw a lot of them. Big one over here is the QDRS. This is something developed by Jim Galvin and our colleagues in Miami. It takes less than 5 minutes. You can use it not just for early detection, but staging over time. So we like the QDRS. And then finally, these 5 cognitive battery that are very, very sensitive. They are very insensitive to your literacy status. So you can have less than 6 years of education. It was the only thing requirement is for you to see it, to have a vision. So this is very easy. We can bypass the clock with this one, and that's the symbol match. And obviously, this is the 4 picture we give you, and trying to see if it work for you or not. So let me end with my father's story, because it's very important for you. I'm supposed to be the expert, correct? I'm supposed to. I've been doing dementia screening for 20 years. We developed all these things, and I missed the diagnoses of my father. And he got a little bit lucky, but I wonder. So my father, a dentist, high educational level, amazing poet, a great master in language, and a good human being, all right? For 2 years prior to April 2020, my mom was telling me, there's something going on with your father. I will go and talk with my father on WhatsApp. He lives in Syria. On WhatsApp video, there's nothing going on. Overconfidence person. All right? I was very overconfident. So for 2 years, I did not believe my mom. All right? And then he developed a COVID, most likely myocarditis, went to acute heart failure, went to the hospital after 2 weeks of shortness of breath. In the hospital, he went there with no medicine. He got out with 5 medication. One of them was Coumadin. 3 days later, he got dehydrated, bled almost death, got delirium because he was the doctor and he was in charge of his medication, but he had an underlying dementia that we didn't even know. So I almost killed my father. Just want to let you know. So since then, we've been trying to take care of him, and God, bless my mom. So don't be overconfident like me. All right? Otherwise, you'll miss vulnerable people, hopefully none of your family member. But that's why we have to optimize. All right? And this is my call. Every time I talk to my father, he's still alive. I look at him and I see the visit to you guys. I talked to him this morning. If I look for your spirit, Dad, I'm trying to help out. So, not because the weather is awesome. So, all right. Thank you. Oh, I have 10 minutes for any question you have. And if I don't have time to answer it, or you don't have a question, I'll be here until tomorrow, 7:30 in the morning. So if you want to
we have microphones too, if anybody would like a mic for questions.
I apologize. I have a comment first. I really appreciate the kind of acknowledgement of the USPSTF recommendations are looking at the asymptomatic population and how fundamentally different that is than the people who have concerns or these, exceeding risk factors, because the prevalence is fundamentally different. And I wanted to ask about the passive digital marker that you mentioned, out of concern for accuracy in the EMR for in Epic. We think about the problem list and diagnostic accuracy, or garbage in, garbage out is always my fear of how has that been a challenge in your system for developing this marker of thinking about how accurate the information it's pulling from is?
Absolutely. Great question. Number one, this passive digital marker, you have to know that we spin it out into a company and I co-founded the company. So just keep that in mind, all right, when I talk with you. So what we developed, the passive digital marker use not just structured data available in your EHR, but the unstructured data. And then we compare it with ICD-9 codes primarily, and that's where the accuracy of almost 80%. Then we replicate it in a completely different population, and that accuracy went down to 75%. And now we are doing it prospectively with the gold standard, and the accuracy is around 70%. So again, it's not high numbers, but it take into account the problem of you don't have enough data, and go from there. So this is why you have to do validation, you have to figure out a lot of other stuff. But by the way, other algorithm, they were able to be smart enough to handle the noise signal, the junk data in and junk data out. But you have to be careful of how to do it. And there's now method to overcome biases, all right? So in algorithm. So there is a method you can do to overcome that, junk in, junk out.
So it's higher level than just, like you said, the structured data marker?
Yeah, it's unstructured. The main driving force is using the unstructured. So we use neuronal network, primarily RNN, to look at your unstructured data that's in not just in your note, but any clinician note, and we use that to find the marker and differentiate. But even with that, you get 75% accuracy, all right? But in the real world, and the MMSE accuracy is around 69%, and the MoCA is 69%. So it's similar. The big difference for us, what we try to do, we use the passive digital marker first step, then 5-cog second step. So we do it like step stuff that will optimize the workflow challenge.
How many years of data or encounters do you
2 years. You need to have 2 years of data encounter, at least one encounter per year. And we can get, but again, you can figure it out.
Did you compare that with the KD score for risk factor for dementia? It's based on literacy level, vascular risk factors,
Yeah. So the big question, there's other risk modifier. Did you compare with it? The answer is no. We develop it on our own using the data, and the data there is the whole purpose of it is optimization. We try to make it, develop it in a dirty world. We call it in the wild, and then you validate it in a completely different wild, and so far it's hold, and now we're doing prospectively. Yes.
Dr. Boustani, outstanding talk. I have two questions to ask you. One is that shouldn't it be almost like a requirement for primary care physician to screen for cognitive decline after a hospitalization or an ICU stay? Because there's almost like a stepward decline, and that's kind of a thing that we are seeing patients never visit that cognitive part. So
I got you.
So that's one question.
Yeah, let's start with that one first. What I'm going to tell you right now is very, very challenging, okay? So what you're asking the question is, can I change the behavior of somebody? All right? And the behavior is the primary care clinician. There's two strategies. Most us scientists jump into what we call mandate, which is policy, all right? Me personally, when I look at mandate, I always worry about unintended consequences. So bias. I don't have there's some data to tell you the mandate versus nudges, the advantage is not too much, right? So I don't think mandate on the long run will fix it, because what will happen, you will do mandate on this, but then what will happen? They will do the screening, just checklist like nursing home, then they're not going to refer the one, they're not going to do it all this stuff, and then all what you did is another regulation, another paper that will never lead to an outcome, all right? So that's my own system way. I always try to use nudges, meaning work on belief of people who don't believe there's a benefit. If I can convert you to say there will be benefit, then you will have an intention, all right? And then intention, unfortunately, become now the gap between intention and action. And there I can do digital nudges, social nudges, physical nudges to help you do, like exercise. All right? Most of us believe exercise is good. We struggle doing it. So we need some people to help us with that. That's my theory, because if you do that mandate, we'll have a triple effect. And then you're going to have to do mandate on all these other stuff. And then all of a sudden, the enforcement of the mandate become more costly than the benefit. Yes. All right? That's my concern. All right, your second question.
My second question is, I'm super excited about development of these passive biomarkers.
Uh-huh.
My question is, because these are also using EHRs, and the timing is whenever the patient comes, and the patient may not come for a whole year. What about the possibility of exploring things like through your, phone has become like our, godsend way to collect data, but, of course, there's a lot of regulation around, but even looking at patterns of driving habits, you're slowing down in your drive, those could pick up probably quickest, signs of cognitive decline. I don't know if any effort has.
Yeah, so the passive digital marker I just shared with you the electronic health record based, okay? But there's a lot of outside the electronic health record, like your watch, your walking, your behavior on Google, a lot of other things that will be the challenge. Yeah, so I used much broader, and our solution was very specific, unique, but everything else is going after that. All right. Last question?
Last question.
All right, last question.
You spoke about, in the breakout session, you spoke about some policy changes in July of 2023.
Oh yeah, the guide.
Yeah.
Yeah. So so the question is, what is this breakthrough, that core policy change that happened in July 31st? We can talk more about it, but what happened is CMS going to be testing an alternative payment model to support the implementation of the collaborative dementia care model. Right? And this alternative payment model, if you are a system that have the data to provide that service, let's call it dementia care service, then Medicare, again, and if they approved you, Medicare will pay you somewhere between $2,500 to $3,500 per member per year to cover your costs. And then on top of it, Medicare going to pay up to $2,500 for respite care requirement for each of your patients. So if your patient needs adult daycare, if they need somebody come over and take care of them. So that's between both of them, that's almost $5,000. So if you have 1,000 patient population you can serve, that's somewhere between $2.5 to $5 million of funding per year for 8 years guaranteed. All right? So this is what happened. Emory and us and UCLA and Hopkins and UCSF are, we call them tier 1. They will be almost automatically approved to start July 1st. And then these centers gonna end up supporting other organizations that are gonna start in 2025. So big, big, big things.
So for other organizations, you have to wait till 25.
No, you will be trained, so you have to apply. Unfortunately, you had to apply last September, last week. You had. Yeah, so Grady gonna do it. They apply.
For this program,
Yeah.
we're going to be in this program. We will start recruiting patients in 2025.
Oh, you're not eligible the first one?
No.
Oh, you do tier 2? Yeah. So they have tier 2. So for Grady, all what they have to do, they need to increase their capacity. So with your network, let them have an amazing capacity and network to deliver it for everybody in the States.
So this is for health systems, not just primary.
Wherever they open for wherever you define system. If you are an CBO, community-based organization, who's able to deliver the model with a coalition, then go for it. I know some area on aging who have a PACE program are going for that.
We're actually a private neurology group in Savannah,
And you going for that?
and we submitted our application.
Here we go.
So they said that towards the end of this year, they might open it up for more people to apply for it, but by 2024 is kind of the cutoff for when they start, so.
Is the application closed now?
The letter of interest is closed, but they might open it up depending on if they didn't get enough letter of interest.
And it's nice because I think each center will be able to personalize what is significant for us. For example, at Brady, social workers will be like a very important part of our population, so definitely want to do the social worker on board. But if your practice, you think that maybe occupational therapy, any other services is important, you could add that too. So it's really like, you could kind of animate the program based on your population.
Sounds good.
I'm done. If you want more conversation, you got 2 experts who did this already. But but at least you know the bureaucracy. So they'll know the bureaucracy, and we'll figure this out. All right.
I wanted to thank Dr. Boustani for his appearance here. We really appreciate that. And he also did a Georgia Memory Net session, a Georgia GMN Insight session earlier this year, and so really appreciate his partnership. Thanks so much.